Good morning, everyone. Wishing everyone a happy new year. Respected sir and ma'am, today the topic I'm presenting is labor analgesia and recent advances. The pain of childbirth is the most severe pain most women will endure in their lifetimes. Women in pain don't need an indication for pain relief in labor. According to American Society of Anesthesiology, in the absence of a medical contraindication, maternal request is the sufficient medical indication for pain relief during labor. This is the statement on pain relief during labor, which was given on October 17, 2007. So, delivery of the infant into the arms of a conscious and a pain-free mother is one of the most exciting and rewarding moments in medicine. So, what is an ideal obstetric analgesic, which can attenuate the maternal anxiety, fatigue, and deliver a healthy baby? The drug which we are going to use should not cross the placental barrier, should have minimal effects on the mother and the fetus. It could be administered in late labor also. It should be easy to administer. It should have a rapid, profound, and consistent analgesia in stage 1 and 2 and preserve the uterine contractility. It should have the onset and offset should match with the time course of uterine contraction. And most important, it should facilitate surgical anesthesia, avoiding general anesthesia, and it should not cause any motor effect, like it should be patient should be able to ambulate with support. Maternal expulsive efforts should be retained, and it should not affect the progress of labor. How should be the local anesthetic? What should be the ideal local anesthetic? It should have effective analgesia with minimum local anesthetic volume and with minimum local anesthetic dose. And most important is it should maintain the uterine blood flow. So, the history of the modern era of childbirth analgesia began in 1847 when Dr. J. Y. Simpson administered ether to a woman in childbirth, and later in the same year chloroform. But it became popular when Queen Victoria was given chloroform by John Snow for the birth of her eighth child, Prince Leopold, and this did much to popularize the use of pain relief in labor. So, before going into the labor analgesia, we should know the stages of labor. This is the first, as we know, there is two stages: first stage of labor and second stage and postpartum. First stage is again divided into phase and active phase, latent phase and active phase, and second stage. So, first stage is from the uterine contraction till cervical dilatation, and second stage is from the cervical dilatation till baby delivery. So, both have their own importance. That's why the stages have been mentioned. So, what is the pathophysiology of labor pain? The first stage has the visceral pain, which is dull, and it covers the T10 to L1 segment, which causes distension and stretching of the lower uterine segment causes this type of visceral pain. When the patient goes into the second stage, it is a somatic pain, which is because of the dermatomes of S2, 3, 4, which is due to the distension of the pelvic and perineal structures and compression of the lumbosacral plexus. So this is the distribution and intensity of labor pain during each stage of labor and delivery. So as you see, this is the lightly brown color, which is moderate pain intensity, and the red one is the severe pain intensity. In the early first stage, the pain will be in the band-like structure in this area of T10 to L1. When it becomes in the late stage, it is very severe pain in this area of the body. And in the early second stage, along with the T10 to L1, there will be in the perineal structures, as you can see, the moderate pain starts. And during delivery, the pain is very, very severe. So, how much pain is too much pain? So, labor pain is the most severe pain a human can bear. And this has been seen by the Magel Pain Index, which measured the pain for all the patients they were admitting in the emergency, and they found out that the pain, which is the red one, 40 to 50, with a childbirth woman with no training, was almost equal to amputation of the finger or toes. So this is the pain a woman bears when there is no training. No training means like a nulliparous woman who is first time doing, or who has not attended any antenatal classes. And even with childbirth, with training, the pain is around 30 to 40. So why it is important to know that why that and how does the labor analgesia helps? What does the effect of labor pain does on the mother and the fetus? When there is a maternal pain stress, there is hyperventilation and respiratory alkalosis. This will cause three things. One is shifting of the oxygen dissociation curve to the left, apneic episodes, and uterine vasoconstriction. This causes decreased oxygen transfer, decreased placental blood flow, and will cause fetal metabolic acidosis. Similarly, because of the stress, the release of catecholamines will cause lipolysis, hyperglycemia, increased free fatty acids, which will increase the fetal free fatty acids and will cause fetal metabolic acidosis. So, when we give a sympathetic blocker within the form of liver analgesia, these things are taken care of. And it is more important in case of patients with systemic disease like respiratory disease and cardiac diseases and pregnancy-induced hypertension, when the sympathetic outflow can further um, be detrimental to the mother not only but also to the patient, also to the baby. What are the techniques of labor analgesia? Complementary and conventional treatments. These are some of the trends: cutaneous electric nerve stimulation, acupuncture. These are the alternative techniques. Another is intradermal saline injections. These are given in the posterior superior iliac spines. 4 points they are given. But we give here systemic analgesia for labor analgesia, starting with inhalation agents. This is Entonox, which is nitrous is to oxygen in 50 is to 50 it comes. We have also this in various VSH hospitals. We do give to our patients. Isoflurane, desflurane, and sevoflurane are the recent advances which have been added. So nitrous oxide provides analgesia within 20 to 30 seconds of inhalation with maximum effect around 45 seconds. Mother is taught to inhale the mixture so that the peak brain nitrous oxide concentration will coincide with the peak contraction pain, and it does not affect the course of the first and second stages of labor and rates of cesarean delivery. But yes, there are disadvantages like the rate of maternal oxygen desaturation will increase. There is direct respiratory depression effect and can be maternal drowsiness, and there is also this is a greenhouse gas and environmental pollution. This is the new recent advances like CVOX, that is CVO with oxygen in a concentration of 0.8% can be used. They have made a study, and an effective liver analgesic, but it needs specialized equipment. It needs more people or more vigilance and more intense sedation. Systemic analgesia, we use intravenous opioids. This is the most commonly used class of drugs. Primary mechanism is analgesia, as well as it can have heavy sedation. Drugs can be given in intermittent or via patient control analgesia. It is inexpensive, and the side effects are like nausea, vomiting, respiratory depression. All opioids will cross the placenta in utero. Opioid exposure result in fetal bradycardia, decreased beat to beat variability, and neonatal respiratory depression. So, what are the parenteral opioids we use? One is pethidine, fentanyl, remifentanil, tramadol, diamorphine, nalbuphine, butorphanol, which can be given by intravenous, intramuscular, and patient control methods. Pethidine is the most common one used in our institute, and these are fentanyl is used in India and Bahrain also. Remifentanil is the newest addition. Pethidine is most commonly used because it is cheap. Intramuscular 50 to 100 milligram can be given. Analgesic effect will be around 3 to 4 hours. And but there is effect on the fetus, like in the form of B to B variability will be lost. Respiratory different depressant effects are more pronounced in neonates, and it has a active metabolite that is norpethidine, which prolongs sedation and respiratory depression. That's why in the second stage of labor it is avoided. There comes the fentanyl. Fentanyl is also sometimes used, short T half and no active metabolites, and it can be given in less small boluses, and it is suitable for a prolonged use in labor. But its advantages, it has minimal neonatal respiratory depression and adverse effects, short duration sedation, and transient decrease in fetal heart rate variability. The newest addition is remifentralin, ultra short acting. Its metabolism is independent of the hepatic or renal function. So some patients with some hepatic disease or renal disease and they are pregnant and you cannot go for a epidural analgesia, you can go with a intravenous remifentanil ultra, which is just ultra short acting, can be tried for. But yes, it needs meticulous monitoring for with from the anesthesia point of view, and it has dose dependent maternal sedation. Coming to regional analgesia, which is the most commonly performed regional technique for labor, epidural analgesia is the gold standard. There are many methods of attaining the regional analgesia. One is epidural analgesia, another is combined spinal epidural analgesia. The newest ones are dural puncture epidural, programmed intermittent epidural boluses, patient controlled epidural analgesia, computer integrated patient controlled epidural analgesia, and also subarachnoid block. So, lumbar epidural analgesia is the gold standard technique. Low doses of local anesthetic or opioid combinations are administered to provide a continuous T10 to L1 sensory block during the first stage of labor. This is safe and effective without appreciable motor blockade, and it can be extended to provide surgical anesthesia. So this is one of the new advances which is being used in many centers in India. Also, we have used patient-controlled epidural analgesia, where this is a machine and it comes with a pump where the it is filled with that with the local anesthetic and opioid, and a setting of a basal infusion rate and a lockout time interval is given, and the patient can give 2 to 3 times. He can press and can modulate the pain relief by giving him the doses by herself in labor. So advantages are excellent patient satisfaction, reduces the total amount of local anesthetic, less unwanted effects like motor block, and reduces the demands on the staff on the labor floor, and gives many participants a feeling of empowerment. So they conduct a study with continuous infusion with patient control top up are better than the bolus only techniques. Another technological advance is in the form of ultrasound imaging of the spine, which will help in identification of landmarks and estimation of depth of the epidural space, especially in obese women and with abnormal lumbosacral anatomy. So as we can see, there is in the transverse, one marking can be done. This intervertebral space can be seen, and this is the posterior complex which marks the epidural space depth, and it can be measured. And this is the spinal canal, and this is the anterior complex. And on the second point, we can see that the paramedian, parasagittal oblique, um, sorry, parasagittal oblique view also, it can we can mark the spaces, and by this technique in patients who are very obese or have scoliosis and all, this can be tried. But then also these have a learning curve. We need a patient who is laboring immediately. We cannot shift the patient with with ultrasound unless we are trained. So these are the doses of the epidural catheters. We use usually bupivacaine, ropivacaine, fentanyl, and sufentanil. Ropivacaine, sufentanil are not available in Bahrain, but we are using bupivacaine, fentanyl. The initial doses can be in the form of 10 to 15 ml, and the concentration and the continuous infusion are managed in the form of 0.06 to 5% to 0.125%. These are some of the complications of the epidural. Every procedure has its own side effects and complications: dislodgement, hemodynamic instability, respiratory consequences in the form of total spinal, sometimes transient paresthesias, intravascular injection, fetal bradycardia, neurological complications like accidental dural puncture with PDPH, direct trauma, cauda equina, adhesive arachnoiditis, and thrombosis of the anterospinal artery. But these are very, very rare complications. One another method is intrathecal analgesia, which is only giving spinal when there is a multipara woman or you don't have a setup. In many African countries, they practice sometimes because they don't have the affordability of using lumbar epidural or epidural catheters. So they have their own disadvantages as for any intrathecal injections, and motor block will prolong the second stage of labor. And the most important disadvantage is there is limited duration with single shot. These are the drugs used for intrathecal. Bupivacaine, fentanyl are most commonly used. Coming to the newest, another technique is combined spinal epidural. This method uses the epidural needle placement followed by insertion of the spinal needle through a side lumen on the epidural or directly through the epidural needle. So as we can see, this is the to his needle, which is the epidural needle. Once we reach the space, it comes with a spinal needle set, which will go into the spinal canal, and it will deposit the drug. So it will and once it is deposited, we can place the epidural catheter in the epidural space. So what are the advantages? It is rapid onset, reliable, fewer failed or patchy blocks, effective saccharine analgesia in advanced labor, better patient satisfaction, adds epidural localization in different difficult bags, and side effects are acceptably low. But there are disadvantages. Like we are not testing the catheter, so basically this is an untested epidural catheter. After 2 hours, you don't know whether it will work or not, and PDPH is that there is a chance fetal bradycardia can happen because mostly it is given in advanced level where there is sudden fall in the adrenaline level which will cause the uterine tetany like situation, and there can be fetal bradycardia. Another recent advance is programmed intermittent epidural bolus, where we give there is a it comes with a pump where the bolus is given not manually but in 60 minutes the machine will give the bolus. The funda is that slow continuous infusion causes drug to exit in a very small area, but when you give a jet bolus injection with greater injection pressure, it will be given in a it will be covering in a larger area, and that all the drug will be exiting from all the holes of the multi orifice catheter. Another technique is dural puncture epidural technique. Here, what they do is they go up to the epidural space, but once, if suppose there is a doubt in whether we have reached the epidural or not, they will puncture it from a spinal needle passing through the epidural needle. And once this, there is a hole created in the spinal, this small hole, and when the catheter is threaded and the drug is given in epidural, it will slowly slip into the spinal and it will give a good dense quality block of epidural. So, what are the drugs for neuroaxial analgesia? Local anesthetics are bupivacaine, ropivacaine, levobupivacaine, and adjuvants can be in the form of opioids, clonidine, neostigmine. Bupivacaine is an amide local anesthetic. Onset of action is rapid. Duration is significantly longer with bupivacaine than with any other commonly used local anesthetic. It has a high protein binding capacity and has a low fetal maternal ratio and relative motor sparing. It is cardiotoxic. Ropivacaine is then comes the ropivacaine, which is a new drug. It's a homologue of bupivacaine, which is S enantiomer. Its latency and duration of action are similar to bupivacaine and has less potential for cardiac toxicity. And ropivacaine is approximately 40% less potent than bupivacaine. This we have used in India. Ropivacaine is available in India. Levobupivacaine, S enantiomer of bupivacaine. It is no difference in onset, spread, and duration, but yes, the important thing is less motor blockade and less cardiotoxic. We have levobupivacaine in VSH. So the adjuvant opioids are usually fentanyl is the most favorite one. Why we are using opioids? The combination of the local anesthetic with the lipid soluble opioid will allow the use of lower doses of each agent, minimize the undesirable side effects. So they are called ultralight epidurals because the fentanyl itself has a rapid onset of analgesia, so it will be helpful. Another is sufentanil. Sufentanil is available in US and UK. In some cases, they are using that there. Newer adjuvants are clonidine. It is an alpha 2 agonist, but most of the centers don't use clonidine as of now. So there are some newer insights in the myths and controversies. Does it prolongs the second stage of labor? Early epidural did not affect the lengths of labor or cesarean rates. It is actually associated with shorter labor compared with late epidural placement. Women managed actively in labor regardless of timing of epidural placement had short duration than controls. Does it increase the rate of epidural and operative and instrumental delivery? The Cochrane database trialed in 2012 have emphasized that epidural analgesia had no statistically significant impact on the risk of cesarean section. RCT and database systemic trials also failed to show significant association between epidural and C-section. And many meta-analysis and COMET study even suggested lower incidence of instrumental delivery after low concentration opioid and LA mixture. So what is the timing of epidural? Shall we give it early versus late? In the randomized control trial of 750 FRIME in early labor concluded that there was no difference in cesarean rate when neuroaxial analgesia was administered early in labor versus a group where epidural analgesia was administered late in labor. So the ECOG and the ASA have jointly emphasized that maternal request is a sufficient indication for pain relief in labor. Does it causes maternal fever? There is minimal increase in body temperature after induction, but it has little clinical significance and not associated with neonatal infection. Can it cause chronic backache? Epidural analgesia has not been associated with increase in the prevalence or incidence of backache. Can it cause transient fetal bradycardia? Sometimes, yes, combined spinal epidural, as I told you, the it can cause uterine tetany with subarachnoid injection of local anesthetic. But if you give without opioids, followed by early initiation of epidural analgesia, it will be better, and it will minimize the risk of opioid-induced transient fetal bradycardia. Can it be given for breastfeeding? Well, will it affect the breastfeeding? Low dose local anesthetic do not clinically affect the breastfeeding and should be still offered to mothers wishing to breastfeed their babies. Is it helpful in postpartum depression? Yes. Epidural labor analgesia was found to be associated with a decreased risk of postpartum depression. Parturient with severe acute pain have 2.5-fold increased risk of persistent pain and 3-fold increased risk of postpartum depression. So this is one of the leaflets which we have taken from Obstetric Anesthesia Association from Mumbai. They have prepared this patient information leaflet. I think this will be very useful for our patients coming for labor epidural. This is how it shows. This is the epidural space, and this is the picture of epidural catheter what we use, and this is the two his needle. And when we place it, we reach the epidural space. We place the epidural catheter there. We show this before starting the epidural procedure. This IV fluid we connect. We clean the patient with antiseptic. We prepare ourselves in aseptic precautions. And what the patient need to sit. The patient need not sit like this because it will decrease the what intervertebral space. Patient should push the lower back out so that the space will open and it will be easy for us to do it. And these are the two positions for epidural. Usually we go with a sitting position, but it can be done in lateral position. And here is how long it will take. Sometimes procedure will time will be 20 minutes, but the medications times will be also there. So we gave a total tentative time of around 40 minutes for pain relief. This is the real scene. And what are the some common side effects? This is itching, which is mild and self-limiting, shivering, occasional drop in BP can be managed easily, and mild numbness because when we are threading the catheter, they may be felt, temporary and reversible. So, risk of an epidural for pain relief during labor and delivery can be in this mild itching, temporary shivering, drop in BP, numbness in legs, which is common. Uncommon is epidural may not work properly, mild to severe headache, temporary nerve damage, and the rare and very rare are in the form of meningitis, abscess, permanent nerve damage. But this thing is very important when we explain the patient. Like what is common when 1 is to 10 means someone in your immediate family. When I say this is uncommon, someone in 1,000 chance, someone in your locality or neighborhood. When I say very rare or extremely rare, someone in a cricket stadium in your city, and extremely rare at a theoretical possibility, 1 in 2.5 lakh. So these are the uncommon side effects: headache, inadequate pain relief, and epidural may not work. Frequently asked questions: will I experience long-term back pain? No, there is no scientific evidence to support this myth. Is this procedure safe for my baby? Yes. Can I ask questions during the procedure? I will be happy to answer all your questions. Happy birthday. Rest assured, with epidural as your companion, the journey here on will be one of pure joy and pleasure. Thank you.